So my topic is treat to target, and the goal of my lecture was really to just start thinking about what is the optimal way of thinking about targeting your patient and really keeping a patient in tight control. The analogy is really about you being the drivers of care and your patient being a passenger in your car. And you have to think about the idea that disease drift happens. You driving your car may drift a little bit, if you're driving in the fast lane, may drift a little bit into the right lane. The whole point is, as long as you get yourself back into the correct lane and not fall onto the shoulder of the road, then you've been able to really quickly and be flexibly enough to move that patient back into the lane of remission. Once they've fallen off the road into the shoulder of the road, assume that means disease flare. It means you haven't been able to be nimble enough with whatever tools we're using, and I'll introduce a whole bunch of tools, the concept of how can I proactively and objectively be able to keep my patient in the lane. And the lane is considered to be sustained, durable remission. That's really what this focus of you being able to consider your patients continuously, durably. Remember, clinical trials look at the past 7 days because they use the Crohn's Disease Activity Index, for example, and say, for the past 7 days, how have you been? It could have been that 8 days ago they were a complete disaster. But if they were good for the last 7 days, they meet the outcome of response or remission. The question is, were they durably in remission throughout the whole year, even in a clinical trial? And so that's how I want to frame the idea that we really want to be thinking about how do we treat to our target. Lori introduced that very cool concept of treating to target in the behavioral space, which I really like. And the question for us is, what is our target? I think that is a big definition. The target for which we believe therapies to be effective has really changed a lot over the last 5 years. I mean, this whole concept of moving away from asking a patient how they're doing and letting it be that, meaning if you feel better, we're good, we walk away, has really been changed really over the more recent years. You haven't heard in past meetings, even out to 5 years ago at the Advances meeting or in this meeting, the idea that our target is going to be objective. Our target has always been subjective, meaning a Crohn's Disease Activity Index, a Harvey Bradshaw, an IBD quality of life questionnaire. If you look at every outcome in a clinical trial to date, never has an objective measure such as endoscopy or Calprotectin or CRP been the outcome of primary outcome for a clinical trial to say that this drug is working. Not one. In Crohn's disease. In ulcerative colitis, mixed in within the Mayo score is the endoscopy assessment, but it's mixed in with rectal bleeding, abdominal pain, physician global assessment, which as you know is very subjective on how you feel that day as a physician, as well as how you interpret the, how the patient is doing. All that get mixed in with the actual endoscopy score. So there's no isolated endoscopy assessment and a clinical assessment. Well, that is completely changed because any new drug coming to market after ustekinumab, so after Stelara, which will be approved September 23rd, after that, all drugs coming to market have to have an objective endoscopic endpoint separate from a clinical endpoint. And what will be the newest to the game is the Crohn story, because we all have seen endoscopy data for UC, but we have not seen endoscopy data for Crohn's. So how do you define treat to target? So this is my go-to Wikipedia. A treat to target approach is known as really this tight control strategy, this ability to hone in and focus on your target and keep someone in very tight control so that your target is always reached. And like I say, this analogy about driving, meaning you're on the road, it's okay if you slip a little bit, but you got to get them back in because you know what the end game is, you know what your target. And where there's a limited time period to adjust, I view veering into the right side, that limited time period and getting right back into the left lane is really thinking about how you keep yourself in tight control. Now, tight control and treat to target, the diabetic literature has really gone on a limb and said, hey, if you could keep an A1C, hemoglobin A1C less than 7%, it prolongs life. They've actually talked to the legacy of survival tied to a target. So for us in the IBD space, defining that target could impact not necessarily legacy and survival, which it may actually, because complications due to perforations and side effects and lymphomas, et cetera, due to overtreatment and or undertreatment in terms of the disease activity. I mean, the idea of thinking about leaving a legacy on survival and the ability in the IBD space to actually impact survival and or morbidity, most likely in that current state, is really, really huge in terms of the IBD context. So the concept of treat to target in a chronic disease state outside of diabetes, which has a drug marker that they could look at to help us improve, the rheumatologists really introduced this in 2010. It's 6 years ago now. To be fair, they haven't adopted it across the board. You ask any rheumatologist, one could say, oh yeah, I'm totally treating, I follow this treat to target algorithm. The other one says, yeah, I just look at their joints. You know, they're using their kind of like blasé approach, and because they have 5 times as many targets as we do, and they switch in between targets easily, like one person doesn't get, you know, within 2 injections may not improve, they're on to the next target. It's this very different way of thinking about their target. The good news for us is that we will have many targets or multiple targets within the next 5 years, but we still are only right this minute. We have one class of therapy that has multiple different options within the TNF class. We have the anti-integrin with Entyvio. And then we'll have, thankfully, a new drug target for Crohn's with ustekinumab in September, October. So their treat-to-target goals are to prolong and maximize the long-term health and quality of life of patients and control of symptoms, preventing progressive structural damage, normalization, function, and social participation, so that speaks to the quality of life. And they believe that abrogation of inflammation is the most important means to achieve these goals. So that means we have to find a way, because we don't have joints to easily look at, we don't have a x-ray of the hand to look at joint destruction, we've got invasive ways of looking at the bowel. We need to figure out, are there objective ways that we may be able to predict what the mucosa is actually looking at? And treat the target by measuring disease activity and adjusting disease accordingly, which means, are we ready as a community that if we have a patient who claims to be clinically doing well but has a calpro elevation or a persistent CRP, are we willing to make a change in therapy, at least triggering us to go look endoscopically, or at least look radiologically, maybe using these markers as a tool to actually get into motion and actually look specifically for the ability to search for an answer as to why these patients are not in control. So what might the target be? Symptoms, growth and development, laboratory values, mucosal healing, as I mentioned, histologic. There's now some increasing evidence from, especially from the ustekinumab trial, which will be very interesting because they're the only ones who really have histology assessment, that patients who had worse histology scores did worse with the drug. So maybe there is something to be said about the assessment of histology, not just the macroscopic assessment, and of course surrogate markers. So I think Jim Markowitz showed you the STRIDE recommendations, but just as a reminder, because I was part of it, I can give you a little bit more insight, is that this was 28 of us from around the world that got together, and using consensus Delphi panel, we all decided if we were going to counsel the community out there, and even ourselves, what should the target be? Should we forgo clinical and go down this road? Should everybody only be defined target as objective? Can we separate clinical symptoms completely? Are we ready to abandon asking a patient how they feel? Doesn't matter. Should we just say, that's nice, I'm sure you feel great, but just we need to scope you to really prove that you feel great. Are we ready to abandon that? And we kind of all got together and said, look, I think it's important that in a patient with UC, we know how many bowel movements they're having and whether they have blood. Those are the only 2 things we care about. And in a Crohn's patient, we want to know whether they have altered bowel movements and whether they have pain. That's it. That is really the crux of what is important symptom-wise from an UC and a Crohn's patient. And we need to match that with an endoscopic objective measure, meaning we need full colonoscopy with ileal intubation in a Crohn's patient, and we need a full colonoscopy in a UC patient. And we need the Crohn's patient to have at least in the early term, meaning at 16 weeks or 6 months from the time of your first drug that you put on, and you're going to assess whether you've reached your target with that drug, that you want at least a 50% improvement in their endoscopy scoring system. And in a UC patient, you want them to have a Mayo score of 0 or 1, 0 being perfect, 1 meaning you have some redness or some edema. But that is your goal. The question is, how often should we do it and when should we do it? Our recommendations were that for a Crohn's patient, you shouldn't look earlier than 6 to 9 months, likely, if you want to really define healing. If you want to look for response, you can probably see a trend somewhere between 4 and 6 months that the endoscopy is getting better. But if you really want to look for healing, probably not before 6 to 9 months if you want to really see that you've made a significant impact on the mucosa. With ulcerative colitis, we felt that within 4 to 6 months, closer to 4, we all kind of felt that the 4-month mark would be the time frame to scope your patients after you've changed therapy or wanted to see whether your therapies are working. And then we said that you should probably measure your patient with some objective measure probably every 3 months. So we made it very kind of this tight control, aggressive objective marker, treat to target kind of time frame if you really want to know if you really want to optimize your patient. Now, why does treat to target matter? Well, treat to target matters is because we as gastroenterologists managing an IBD patient have a very, very, very small window. This is a window where before bowel wall damage happens. Once bowel wall damage happens, our drugs are only going to be as effective as they can be, because bowel wall damage means scar tissue. So if you have bowel wall damage that's already occurred, the goal of our treatment is to prevent further bowel wall damage, which means trying to keep them as stable as possible so that at least you won't get progression of the bowel wall to become more thickened and fibrotic or fistulizing. So it probably is that our best window of opportunity is really, really early. That is why the importance of this, yesterday I was talking about this reactive step-up concept. And if you can't risk stratify, like Robin showed you yesterday, of defining who is that patient that is going to progress so that I could diagnose, prognosticate, and treat within 90 days of diagnosis. That needs to be your focus because we've shown that, did you show the model yesterday? Yeah, so we've shown that what happens in the first 90 days shapes the long-term complication rate. So that's why it's important to really know what are those risk factors for progression. Because once you start down this path of stricture, fistula, surgery, stricture, and you haven't altered the bowel wall damage progress, you're really going to get into problems of not really moving the needle. And our historical perspective of Crohn's, and we've all been in it, is we've kept our surgeons as busy as they had always been. And it really wasn't until we started seeing, and Fernando will show you, that really the impact of effect is early, before bowel wall damage happens. And that's really, I think, where that post-hoc analysis on Sonic that Fernando's going to talk about really is critical in terms of understanding disease, deep remission. So this is how our goals have changed. Imagine we went from how are you doing, are you better, do you have a good quality of life? And every clinical trial, and if we remember, the anti-TNFs were really infliximab, that was the approval. This was it. This is what it was. Then you move to, let's say, adalimumab approval, remission was an outcome, golimumab approval, remission was an outcome, and then vedolizumab was an outcome similar to this. But there was this idea now, imagine that we're getting into this idea that drugs can't come to market unless patients are in deep remission, meaning endoscopic healing, maybe normalization of objective markers, and looking at minimal disability, and really this idea of sustained disease control. So this is like a whole other landscape, and that's all happened in like the last few years. So it's a rapidly moving target, no pun intended, that we keep changing and the FDA is following along. So yesterday I showed that we're really not thinking about this proactive and reactive approach, and really the way we do it is we require failure of one step or class before moving on to the another. We imply static treatment levels and don't address changes over time, meaning we're not assessing the patient, actively enough and saying, come back to me when you're sick. Well, someone did do this. I showed you this yesterday, the ability to really be nimble and be flexible and be able to really appreciate that having a patient come back when they're sick isn't going to get you in that proactive disease monitoring state, and you're not going to achieve your target of interest. Well, maybe what I said isn't true, but I think it is true. The reason why I'm saying it's not true is this study actually looked at, which was called the REACT study, where they actually looked at and had people come every 3 months, and in every 3 months, if they weren't better, they kept trumping the other treatment strategy. They would go from adalimumab with immunomodulator. 12 weeks later, you're not better, I'm going to go to weekly adalimumab with your immunomodulator. 12 weeks later, if you're not better, I'm going to change you from 6-MP to methotrexate. 12 weeks later, if you're not better, I'm going to recommend surgery. This was this REACT 1 kind of tight control arm study saying you may get better outcomes. Well, interestingly, if you use asking a person, how are you feeling, which gets back to my whole idea of subjective versus objective, if you use the Harvey Bradshaw Index and say, how are you feeling today, Mrs. Jones, if I kept you in tight control and saw you every 3 months, versus Robin not seeing her patient until they come back sick, that was the comparative group, is just standard of care, come back whenever you're feeling, unwell. If I use the Harvey Bradshaw Index at a year and even out to 2 years, no difference in outcome, meaning symptomatic outcome. But look what happened when you start to objectify your outcome. When they looked at hospitalizations and surgeries and infections, you could see that when you use a come see me every 3 months approach, you actually got a 27% reduction in complication rate, driven predominantly by hospitalizations and surgeries. Now, the REACT 2 trial, which realized that, hey, using Harvey Bradshaw is so not the way to actually define whether or not tight control is important, what they did is if you go back to what they're doing here, is instead of doing, are you feeling better, Mrs. Jones, they're looking at CRP, Calprotectin, and colonoscopy every 4 months, and adjusting therapy based on an objective measure. So you could imagine that these lines are going to be very wide apart when you start using objective measures to keep a patient in tight control. So we anxiously await REACT 2 because we realized that although REACT 1 was lovely and it involved 1,600 people, it didn't move the needle when it came to what we were typically doing is, do you feel better because I see you every 3 months, and assess, are you feeling better, without measuring an objective way of telling me that you feel better. So it's really important to remember that objectifying the outcome is critical. Now, the SONIC trial really made it very clear. And this is what really made the FDA go down this line that, one, to get into SONIC, which was the important combination immunomodulator, Imuran plus infliximab versus infliximab alone versus Imuran alone, you didn't need any endoscopic evidence to get in. All you needed was a Crohn's disease activity index, which, remember, someone with irritable bowel syndrome could meet a 220 CDAI criteria to enter, because abdominal pain, diarrhea, and well-being are the most weighted items in the Crohn's disease activity index. So it's not surprising that 20% of patients who entered SONIC had zero evidence of endoscopic assessment, because we videotaped all the endoscopies and sent them to Belgium to be read. And lo and behold, 20% of people who entered SONIC had no evidence of disease. So we enrolled IBS on top of IBD patients. But more importantly, when they looked at the outcome at 26 weeks, patients who were in clinical remission, approximately, let's say, make it simple and call it 55, approximately 45% of patients still had endoscopic ulcers. I feel great, I'm in clinical remission, but my endoscopy is not normal at 6 months. More importantly, 30% of patients who said, I feel terrible, had a completely normal endoscopy. That's the group that I sent to Lori constantly, every day. Lori, this patient's in complete remission, still has abdominal pain and whatever other symptoms, and she fixes that with her hypnotherapy. But that's the whole point, is that there is a huge amount of patients who have this IBS overlay that would be confused as a failure in a clinical trial. FDA said, well, we're done with that. We're using objective measures only. Endoscopic response has to be a part of your ability to even get into maintenance. They're making the drug trials look at 12 weeks to see if there was any endoscopic improvement and randomize you only if you have endoscopic changes. I mean, this is a huge change literally in the way we're doing clinical trials, and we'll limit drugs that come to market except that those that actually move the needle in terms of endoscopic assessment. So maybe more difficult to get drugs approved, but imagine the power of those drugs that do get approved. So this is why it's an exciting time in the IBD trial space. So the goal of tight control is to keep remember how I had this position where I was going up and up and up in terms of my bad outcomes, but what I'm doing here is I'm keeping people in very tight control and keeping them solidly on this flat course of not progressing to complication. Now that's the nirvana of managing this tight control patient, but we have the tools. We know that in a patient, here's one of the questions from the pretest. Whoops. The group in Pittsburgh actually took patients who were in quote unquote quality of life remission, so using the IBDQ or a certain shortened IBDQ, and followed them over time. And there was 178 patients. Okay, doc, I feel well, but they went back and they saw that those patients who said, I feel great, but had CRP elevation, there was a 30% change, so you went from 7% to 37% increased rate of hospitalization within the follow-up period, and the majority of these hospitalizations were for ileocecal resections for stricturing disease. So patients say, I feel good, but they have an objective measure of inflammation. You need to assess that patient, and until you have objective evidence that patient does not have IBD inflammation endoscopically, consider that symptom description to be irrelevant until you've proven that you have no objective measure. And that is a really culture change on the way we need to manage IBD patients. And I promise you, you will change the lives of IBD patients if you follow a much more objective measure of evidence of disease. The same group actually showed us that if you look at, so the Le Mans Index is a very complicated way of measuring bowel damage. It's named after a colleague of ours, Mark Le Mans, who unfortunately passed away from cardiac arrest at a very young age, but this was his index, and him and the French group from the Jatade group put together this way of looking at bowel wall damage. They were 10 years ahead of all of us, recognizing that bowel wall damage is what leads to strictures and fistulas, and it's a complicated way of measuring it. There's a whole Excel file that you need to fill out. But anyways, I think you could just imagine the idea that if you took the time to look at it, you could imagine that those patients who had CRP elevation, but yet we didn't do anything, their bowel wall continued to progress to bowel wall damage, no matter how great the patient said they were. So this is even more of an objective evidence that CRP is tied to progression of bowel wall damage. Fecal Calprotectin, one of my favorite tools of actually objectifying what's going on in the mucosa, especially in a patient who has large bowel disease, it's even better. Small bowel disease has been shown to be good, but I think the level of Calpro really matches more the colonic inflammation. This was a group of patients who were in remission on at least 6 months of adalimumab, and they showed that relapse rates were those patients who relapsed versus didn't. The calprotectin level, that although the patient said, I feel great, but the Calpro level was measured, showed that calprotectin predicted flare in these patients, despite them saying they felt good. The whole story really, no pun intended, started with the STORY trial. The STORY trial is another French study where they took people off of infliximab after they were in a durable remission or so-called durable response remission for 6 months on combination therapy with thiopurines and infliximab, and they showed that the calprotectin elevated and the CRP form up to 4 to 6 months before clinical flare. So this was another example that calprotectin is elevated before flare even happened, and this was they were blinded to it, and patients flared off of infliximab, and we looked and we said, which of the patients that we could have predicted were actually going to flare? And it was these patients who had high CRP and high calpro. And it was just showing you that of all the markers that actually had the highest predictability or the positive predictive value of being able to predict what's going on in the endoscope, you can see that CRP and lactoferrin and calprotectin have a high correlation or positive predictive value of telling you that you have endoscopic inflammation. So I'm not telling you to make a change based on an objective measure that's a lab test. I'm telling you to go look and to prove that to the patient and get the patient into this dialogue. Doc, I think it's time for my calprotectin measure. What is my last calpro? Do I need to be scoped? You need to change your conversation, and you need to get patients into this idea that in order for you to prevent surgery, I need to see what's going on inside of you. It's a really, really important language skill that we all need to get, and communication is about it. This was even in the post-op setting. They showed that actually calprotectin predicted the Rutgers score that Fernando will talk about in the post-op setting. So when you looked, and they actually showed that calprotectin correlated with the Rutgers score. So calprotectin may be a way of actually telling you whether your patient post-op has a recurrence, and meaning a Rutgers 2 or above, or a 3 or a 4, which Fernando will show you what that score system means. But they even went as bold to say that maybe if you have a normal calpro, maybe you don't need your 6-month colonoscopy in a post-op patient. I'm going to tell you to hold the brakes on that. That's not accurate, in my opinion, yet, until it's proven 100%. But what I would say is I'm now doing calprotectin 8 to 12 weeks after surgery in a patient, for example, who's on therapy or not, to tell me whether I may need to scope my patient earlier or not. So I'm actually using calpro in the post-op setting before even the 6-month endoscopy. So in terms of endoscopic assessment and treat to target, what I want to say in the last few moments is that they actually tested this in UCSD. Bill Sanborn went back and said, if I had a patient who I scoped 6 months after I started a therapy, and I adjusted my therapy based on my endoscope, was I able to improve the rate of endoscopic healing once I actually increased my therapy or escalated? And he was able to take up to 70% of patients with mucosal healing by adjusting his therapy based on a 6-month endoscopy after he started whatever therapy he started. So the ideal, it is the ability to actually objectify your outcome, find your target, and adjust accordingly. And this is this whole target. You need to reach it. You decide based on what Robin talked about yesterday. You risk stratify. You decide this patient needs whatever therapy. I don't care actually what therapy you're using. As long as you use your therapy according to your risk, you decide your target, which is an objective measure, hopefully your mucosa. If you haven't reached your target, you come back, you re-stratify, redo another therapy. The cycle continues. Don't give up on the cycle until you've achieved your outcome of interest. So in summary, treating to target and achieve target and disease monitoring. The movement is here. We're here. It doesn't matter whether you want to embrace it or not, but I would ask you to embrace it, because the FDA and all drugs moving forward are going to be based on this strategy. So we need to be current, and we need to be practicing in the current era. Precision medicine approaches may include a treat to target using an assessment and serial adjustment of therapy to achieve validated endpoints. Monitoring is the key to achieving goals and keeping patients well, and you need to monitor for response to therapy, adherence, and remember that concept of disease drift, and get your patient back into the fast lane so you can minimize complications and optimize the outcomes of your patients in the long term. Thank you so much for your attention.